Today, we're diving into a rare but really critical condition where the heart and lungs, two partners that are supposed to work in perfect harmony, end up in a high-stakes standoff. We're talking about pulmonary arterial hypertension, or PAH. Think about the heart and lungs. They're this perfectly synchronized team, right? The right side of the heart gives this gentle push of blood into the lungs to get oxygenated. But what happens when that partnership just breaks? What if the lungs, for reasons we're about to get into, start to resist that push? That resistance? That's the core problem in PAH. Okay, so let's get the official definition on the table. At its core, PAH is a very specific kind of high blood pressure. It only hits the arteries in your lungs and the right side of your heart. But the real issue isn't just pressure, it's that the blood vessels themselves actually change. They get stiff, they get narrow, they're remodeled. And that creates a ton of resistance that the heart has to fight against with every single beat. Now, here's something you've got to know. Pulmonary hypertension is actually a big umbrella term. There are 5 different groups, and the cause could be anything from left heart disease to chronic blood clots. But what we're focused on today, pulmonary arterial hypertension, or PAH, is specifically group 1. It's its own distinct disease with its own causes and, as you'll see, its own super targeted treatments. To really get what's happening in PAH, we've got to zoom in, way in, down to the microscopic level of the arteries in the lungs. What is actually making these tiny pipes remodel and get so narrow? Let's go take a look. And wow, this image tells the whole story. Just look at the difference. On the left, that's your healthy pulmonary artery. It's wide open, it's flexible, the lining is nice and thin. Now look to the right, at the artery with PAH. You can literally see how the muscle layer has bulked up. That's the medial hypertrophy. And the inner lining is all scarred up. The result? A narrow, stiff tube that makes it incredibly hard for blood to get through. So, what's causing all these physical changes? Well, it all comes down to an imbalance in 3 key molecular pathways. In a healthy person, things are perfectly balanced. You've got nitric oxide and prostacyclin, which act as relaxers to open up vessels, and then you have endothelin-1, which is a constrictor. But in PAH, the whole system just goes haywire. The body makes too little of the good guys, the relaxers, and way too much of the bad guy, the constrictor. This leads to this constant state of squeeze and harmful cell growth. This quote from the source material just nails it. The lungs are supposed to be this easygoing, low-pressure, low-resistance circuit. But PAH completely flips the script. It turns the lungs into the exact opposite, a high-pressure, high-resistance battleground where the vessels themselves are actually growing and changing for the worse. So with all this crazy stuff happening deep inside the chest, how on earth do doctors figure it out? The thing is, the symptoms, like being short of breath or tired, are super vague and can look like a dozen other things. So the whole diagnostic process is kind of like a detective story. You start with broad clues and slowly narrow down to find the real culprit. You can think of it like doctors climbing a diagnostic ladder. They start on the first rung with screening tests, an ECG, an echocardiogram, things that might hint at strain on the right side of the heart. If those raise a red flag, they climb to step 2, tests to rule out other causes, like checking for blood clots. But to get the final, definitive answer, they need to get to the very top of that ladder. And here it is. The one and only way to know for sure if it's PAH is a test called a right heart catheterization. This procedure isn't just an estimate. It directly measures the exact pressures inside the heart and the pulmonary arteries. It is the absolute gold standard because it gives doctors the cold, hard numbers they need. So what are these numbers they're looking for? Well, the first piece of evidence is the mean pulmonary artery pressure, or MPAP. A normal pressure is way lower than this, so a reading of 20 millimeters of mercury or higher, that is a huge red flag. That's criterion number 1. Now, the second number is the wedge pressure, or POP. And this is the fascinating part. This number has to be low, 15 or less. Why? Because this tells doctors that the pressure isn't just backing up from a problem on the left side of the heart. It essentially isolates the crime scene and proves the problem is starting right there in the pulmonary arteries themselves. And finally, there's the pulmonary vascular resistance, or PVR. This is the number that directly measures that pushback from the lungs we were talking about at the very beginning. A value of 2 Wood units or higher confirms that the heart is fighting against some serious back pressure, and that pretty much seals the deal on the PAH diagnosis. All right, so once the diagnosis is in, the story completely shifts from detection to action. And thankfully, we're in an era with a powerful toolkit of therapies that can fight PAH at the very molecular level where the whole problem starts. So remember that constrictor molecule, endothelin 1, the one that's being overproduced? The first big treatment strategy is to go right after it and block its harmful effects. This is done with a really smart class of drugs called endothelin receptor antagonists, or ERAs. These meds, like macitentan, basically act like a shield. They park themselves on the receptors where endothelin would normally attach, and they physically block its signal to tighten the vessel and cause all that harmful cell growth. It's a really clever approach. Okay, strategy number 2 is to go on the offensive. We need to boost one of the body's natural relaxer pathways. The goal here is to crank up the signals that tell the blood vessels to chill out and open up, and the nitric oxide pathway is absolutely key for that. Doctors do this using drugs you might have actually heard of, like sildenafil and tadalafil. They're called PDE5 inhibitors, and they work by stopping the breakdown of a crucial messenger molecule called cGMP. You can think of cGMP as the final relax signal sent to the vessel. So more cGMP means more relaxation and much better blood flow. Simple as that. And that brings us to the third and final major therapeutic target, the prostacyclin pathway. This is another one of those super important relaxer substances that people with PAH just don't have enough of. And replacing its effect is often vital, especially when the disease is more severe. Now, these are some seriously powerful drugs like epoprostenol and treprostinil. They basically mimic what natural prostacyclin does. They hit a key receptor that triggers powerful vessel relaxation, and they have an awesome second benefit. They help stop platelets from getting sticky and forming clots inside those already narrow arteries. They are an absolute cornerstone for treating advanced PAH. So, after all that science, why does this matter so much? This slide right here puts everything into perspective. It really wasn't that long ago that a PAH diagnosis was just devastating. Survival was often measured in just a couple of years. But today, because we can fight this disease on all 3 of those molecular fronts, patients have a real shot at a much, much longer and better quality of life. The progress has been nothing short of incredible. You know, the story of PAH is such a powerful example of this revolution happening in medicine right now. Going deep, understanding the molecular roots of a disease, and then designing smart, life-saving treatments. And it leaves us with this one really exciting question. As we get better and better at targeting the specific pathways of more rare conditions, what does that mean for the future of medicine? What's the next big frontier?